Thank you so much. As Stefana said, I'm Annie Lassway, and I'll be talking to you about the use of Bayesian networks in predicting the optimal revisit intervals for patients with type 2 diabetes by using a CMS dataset. LASSO actually stands for the least absolute shrinkage and selection operator. But before I get into the details of this study, as Stefan had mentioned, I work at MITRE Corporation. As many of you know, it's a nonprofit organization that actually operates federally funded research and development centers. It's about 60 years old or so, and it has about approximately 8,000 employees. So I'm actually based in the Virginia location. I'm a healthcare researcher and a senior analyst at MITRE. Now, I'm also a doctoral student. I'm actually getting ready to graduate December this year. I'm studying health services research and a concentration in informatics. And I was first introduced to Bayesian networks actually by my mentor, Dr. Farouk Kalemi at George Mason University. And he's an integral component of this study as well. So let's get right to it. As healthcare researchers, when it comes to feature selection, this is a very crucial and challenging task. And when it comes to building a model, sometimes picking those variables that need to be included for predictive analytics, especially when it comes to healthcare research, it tends to be something that is a topic of great interest within my field. Historically, we see that feature selection is made based off of heuristics and provider experience or researcher experience. And so, as we've learned a lot from Judea Pearl in his book of causality, leaving causality in the hands of intuition and judgment is actually an impediment in research. So this method, LASSOSql, is actually sort of a coined term that we've used amongst us in our study, is a new method that overcomes this challenge, and it builds upon Charget's least absolute shrinkage and selection operator, but it's executed solely in SQL, and it uses Bayesian network principles. So I'm actually kind of glad that I followed after Dr. Michael Thompson's presentation, because he talked about a lot of the principles that I will also be discussing as well. So in this study, I'll demonstrate the effective use of this methodology by actually applying it to CMS data in order to predict the optimal revisit intervals for patients with diabetes. I'll go into a literature review. I'll talk about what started this study and why we're actually interested in this particular topic. I'll go into the methodology, and then afterwards I'll talk about sort of the next steps, the use of Bayesian labs, and which is part of our next steps, and also assumptions and limitations of this study. The outcome of interest for this study is actually kidney disease. As I mentioned, with diabetic patients, we're trying to basically control and monitor and find that optimal revisit interval before they have those adverse effects. And the one that we have selected is chronic kidney disease. In this study, we are also using all the variables that are available in the claims data set. So we're using all the demographic information and every single diagnosis and comorbidity that's available in the data set. So let me talk about revisit intervals. It's basically a fancy way of saying the follow-up intervals. So it's a time between two consecutive appointments. It's actually defined as the number of days between two consecutive appointments in an outpatient setting by the same patient and also by the same provider. And that's how it's calculated in this study. And so revisit intervals tend to be scheduled also based off of experience and heuristics based off of providers' knowledge and what they think is best. We find that when it comes to acute or complicated cases, physicians would agree that patients need to be seen sooner. And also, when it comes to longer revisit intervals for patients who do need to be sooner, that could lead to adverse effects and complications. And when it comes to diabetes, it could be kidney failure, eye damage, blindness, could be also heart disease, stroke, etc. So patients can have better healthcare outcomes, and providers can optimize their schedule and increase access as well by optimizing the revisit intervals. Now, when you think back to the implementation of the Affordable Care Act, for example, that increased access to care for upwards of 30 million US citizens and residents, when it comes to access to care, that became more of an issue. Now, where there are a lot of initiatives and studies that look at increasing nurse workforce shortages or primary care providers. But this study is actually looking specifically at optimizing the current available appointments, optimizing the current patient or provider grids to see how we could see patients or providers can see patients when they actually need to be seen. Now, although this study focuses on outpatient setting, within the team that we're studying this, there's also can be applied to an inpatient setting as well. In that case, we use length of stay, we can use admission days in order to determine the optimal revisit interval. So when it comes to sort of background information and sort of the impetus of this study, there are many reasons that could cause variation. We're seeing that there's association between provider specialty types, and also there's variation between gender. Female providers tend to have shorter or assign shorter revisit intervals than their male counterparts. We're also seeing that when it comes to highly hypertensive patients or patients with acute diabetes, there's very little evidence-based assignment of revisit intervals. There's also high variation based off of, when it comes to shorter revisit intervals as well. Now, in comparing the revisit intervals or the prognosis of patients with type 2 diabetes, it can be misleading a little bit when you look at the correlation between, for example, their testing of hemoglobin A1C and also the determination of the assignment of the revisit intervals. Now, there are some guidelines, though. So, for example, the American Diabetes Association, they recommend guidelines on testing for hemoglobin A1C, and that is every 6 months. However, they do recommend that tailoring and customizing for specific vulnerable populations is very important. And again, this is for testing of hemoglobin A1C and not necessarily the revisit intervals. Now, there are other sort of higher frequency revisit intervals, and when you look at the Japanese Diabetes Association, they recommend testing every month. The National Institute of Health and Care Excellence in the United Kingdom, they recommend testing every 6 months. And however, and I call it NICE, but NICE, just like with the United States, they also recommend a very individualized approach in determining and tailoring patient care based off of the patient's needs. So why diabetes? So according to the National Institutes of Health, there are approximately 30 million people in the United States living with diabetes. And this is costing the economy approximately $327 billion. $237 billion of that is in direct medical cost, and $90 billion is counted for with the reduced productivity. Now, again, as I mentioned before, there are opportunities for improvement. You can maximize the patient grid, you can maximize that provider grid in order to see patients exactly when they need to be seen. So according to the National Health Statistics Report for 2009, there are nearly 1 billion office visits, and 30% of those are for routine follow-up care for chronic illnesses, and 26% is for acute conditions. The Commonwealth Fund study that was conducted in 2010 shows that out of 11 industrialized countries, the wait times for to be seen in the United States is leading, with the exception of Canada, Norway, and Sweden. So clearly there's opportunities for improvement there. So in this study, basically we're looking at variations between providers and also between provider practices. There are some practice guidelines, for example, with Kaiser Permanente, they have guidelines on when they need to see diabetic patients for follow-up visits, but that varies from practice to practice and also provider to provider. And so we're looking for, between groups and within group variation as well. Another part, which is a component of the methodology, and this will be clearer a little bit later on when I talk about the actual steps, is the research gap. This methodology that we have is actually using stratification. It kind of moves a little bit away from Rosenbaum and Rubin's potential outcomes for propensity score matching, because it doesn't use potential outcomes and doesn't use counterfactuals. It uses stratification. And basically with that is that we use every single diagnosis code in our study and every single comorbidity coupled up with the age of the patient because if a patient is diabetic at the age of 65 versus if they're diabetic at the age of, for example, 85, could be significant differences in the healthcare outcomes. And then each comorbidity is actually coupled together to form a new attribute because the combination of the comorbidities also can factor into the predictive model. So again, the research objective is to explore the usefulness of this methodology using claims data to predict the optimal revisit intervals for patients with diabetes, with a goal of providing a tool that can be implemented directly in the electronic health record, hence the SQL part, and used by clinicians to optimize patient revisits and improve healthcare outcomes. The importance of using SQL is so that it could be directly implemented as a decision-making tool. And basically, it kind of, in a way, circumvents the having to export the data, which could be time-consuming and costly as well. And also there's other hurdles such as patient privacy, IRB, because it's being used for research. So having it implemented directly in EHR is important. And we're looking to use Bayesian Labs to sort of test the accuracy of our methodology, which uses Bayesian networks. So the study aim is to demonstrate the effective use of the methodology, and the second aim is to determine the actual causal relationships between revisit intervals and kidney disease while taking into account patient comorbidities for diabetic patients. Revisit intervals are categorized in two ways: long revisit intervals and short revisit intervals. Long are actually defined as one standard deviation above the median once we looked at the entire data set, and short is one standard deviation below the median. Again, the data set is CMS data set, and this is available at the George Mason University virtual environment. We're using claims data from 2014 to 2016. The sample size is 136 million cases, and the number of distinct patients are a little bit over 800,000. The reason why we chose CMS dataset is because it's one of the largest, most comprehensive and robust datasets out there. When you look at other private datasets such as Blue Cross Blue Shield or United Healthcare, they tend to be very disaggregate, sometimes introduce some bias depending on the location and where it's being used. But CMS actually captures 98% of adults over 65 years old, and also contains 45 million beneficiaries, and also patients, 99% of deaths in the United States are actually captured within this data set and are above the age of 65. So we thought this is probably the best data set to use for our study. The inclusion and exclusion criteria, basically, we excluded patients who are in the data set below the age of 65 because they tend to be sicker and hence have Medicare coverage, and that can skew our results a little bit. So those were excluded. However, all the other components in the claims data set were included, and we limited it to outpatient data. So now going into stratification. So basically this involves comparing two outcomes or two scenarios, but by holding one difference. And that difference is basically attributed to the treatment. So in one scenario, the treatment is applied, which would be our cases, and the other case where the treatment is not applied, that would basically be our control. So we use directed separation. Basically, it's an alternative way of basically holding everything constant with only one difference. And through that, we identify the Markov blanket, and that's what we use to sort of feed into the machine learning model. A quick highlight of the conceptual framework. Basically, we first determine the association between our outcome of interest and all the features or the comorbidities. We determine the sequence of events, in which in claims data is very important to determine when the kidney disease occurred versus when the patient had different diseases or comorbidities. The mechanism, we look at also backdoor pathways and blocking certain backdoor pathways which are open based off of our analysis. And then we look at the counterfactual as well. So theoretically, if in the presence of a certain diagnosis we see kidney disease, then theoretically in the absence of that diagnosis, we don't expect to see kidney disease. So that's sort of like a very high level. And I'm kind of following Sri's methodology of keeping it very, very simple. So again, in high-dimensional data set, it's very important to basically look at the backdoor pathways and identify the Markov blanket. So in holding comorbidities ceteris paribus, or to hold it constant, we're able to isolate the treatment effect and the observed differences. The Markov blanket of the treatment group are basically the covariates that are basically indicative of the long revisit intervals and also the kidney disease occurrence as well. This will be clearer once I go through the methodology itself. At this point, I'm just providing sort of a high-level conceptual framework. So the Markov blanket actually includes the direct courses of course, as you know, parents, co-parents, as well as the children. However, in this study, we're looking at just the parents of the Markov blanket. So in this predictive model, we're basically dropping all the claims data that is after a specific index date that was assigned, and we're using all the a priori knowledge to feed that into the machine learning model in order to predict the positive or negative outcome of kidney disease. Within that, so basically we feed every single variable that we have in our data set, and then we isolate what is basically significant based off of the likelihood ratios, and that is what we learn further to determine the likelihood ratios. And this is actually executed in Postgres. So the parent Markov blanket is basically simply just calculated based off of the likelihood ratios. We determine the counts of the desired outcomes in the presence of a diagnosis versus the absence of the outcome in the presence of the same diagnosis. And we continue on determining the conditional probabilities. Theoretically, we also indicate the usefulness of an element by also determining the inverse of the likelihood ratio as well, and looking at the associations between the predictor and the outcome. In blocking backdoor pathways, so basically what we're doing is looking at the treatment variable D on the outcome Y, we have to look at all the other comorbidities, hold them constant, and control for them so that we can really attribute that the outcome of interest is based off of the treatment itself. And I won't go into this in much detail, but basically we're holding everything else constant or controlling for the other comorbidities in order to determine the actual causal path between the treatment D and the outcome Y. So now let's go to actual methodology. So the steps that we've taken is basically randomization. First, we find a randomized index date based off of the patient's appointment for each individual patient. We remove all the tautological predictors, which is basically removing all the predictors which occur after the assigned randomized date. We include the age factors. Each and every diagnosis is basically coded with the age and become a new variable based off of the age. So it'll be diagnosis age. And then we find the average revisit interval as well as the median revisit interval and determine those long and short revisit interval cutoff points. When we actually started looking at this first, we wanted to just use the average revisit interval and look at those predictors right above and below, but we found that the patient characteristics between those which are a little bit above and below tend to be the same, so we ended up switching to using standard deviation. Then afterwards, we calculate the likelihood ratios and basically fill in those variables A, B, C, D within the contingency table of looking at the presence of a diagnosis in the presence of kidney disease, the presence of the same diagnosis in the absence of kidney disease, doing the same for long and short revisit intervals, and then looking at the similarities between those identified comorbidities between kidney disease contingency table and the revisit interval contingency table, and using that to determine the sensitivity analysis. We also determined a specific cutoff point. So once we determined all the covariates that are indicative of the long and short revisit intervals and kidney disease, we looked for a cutoff point that gives us a large enough chunk that is also still manageable for further analysis. We also looked at so by doing that, we looked at the likelihood ratios, which are of the highest counts based off of the analysis. And basically, once we found the ones that are on the I guess the long revisit interval side, and then also on the positive kidney disease side, we pull those to the side because they actually are covariates that can impact both revisit intervals and kidney disease. And we continue doing the same throughout the analysis. Again, we looked at the inverse likelihood ratio as well, because the absence of a diagnosis could also give us additional information of whether that would also lead to the absence of the outcome of interest. So stratification is a list of with stratification, the covariates are basically stratified, and within each strata, we hold everything constant and examine only those differences based off of the outcome. And so we divide the strata into different subgroups, and within each strata, we use basically the group by clause in SQL and isolate what the differences are and looked at those separately. Then we determined a 95 confidence interval, and that's calculated in the equation on the bottom left corner. And the 95% confidence interval was calculated based off of our specific data set, and we did a sensitivity analysis. What we've done is that we dropped each and every covariate one by one, and then tested to see if the odds ratio changed after we dropped that specific covariate, and also if it changed beyond the assigned confidence interval. And then if it did change quite a bit, then that means it probably has a significant impact on the outcome. And we did this after we dropped the covariate, we returned it back into the data set and moved on to the next covariate and looped it like that. The significance of the study is that, again, the American Diabetes Association does not provide these guidelines, and we need to optimize our appointment slots in order to increase access and provide care to patients who actually need to be seen. The ease of use is that it can be implemented directly in an EHR. However, like I mentioned earlier, we need to actually verify that our results are actually in line, and we would need to use other statistical software, and we're hoping to use Bayesian Lab to actually test the model to see if we get the same outcome. And then when it comes to management, the results of which can actually help inform policy. When it comes to patient care and also outcomes, and within practices or maybe within medical training, we're hoping that this could actually help improve the outcomes of patients. And lastly, there's a quote there that I actually really like. It's for decision science. It actually says, evidence-based follow-up intervals have the potential to reduce healthcare costs per person and improve access without compromising or restricting care. And that's actually published in the Journal of Managed Care. Now, just like any study, there are quite a few assumptions and limitations. When it comes to practice providers, as I mentioned, the revisit intervals are calculated as the number of days between 2 consecutive appointments by the same patient by the same provider. However, sometimes providers practice as part of a practice. So if a patient is seeing their colleague, their revisit interval is actually probably shorter than what we've calculated. Also, when we condition or block off other covariates in order to determine causality, new backdoor pathways may also open, but that's something that we're probably looking into sort of analyzing further. And also there's the assumption of independence. So we use naive Bayes formulas in our analysis. And so the assumption of independence is actually not verified. Then we also assume a finite state. Even for the patients themselves, we assume that the patient's healthcare status are actually frozen in time and don't change, or their diagnosis or comorbidities remain the same over time. And also, when it comes to knowledge about the node, we assume that all the information that is needed or encoded within the node is present there, and all the information needed about the neighboring node is also coded. The data set we're using is CMS data set, and so it may not necessarily be generalizable to non-Medicare patients, because though it's the most robust and comprehensive data set, the patients are older and may have specific conditions or needs. And that is it.